and twirl it. There's a kind you put the needle in and electrocute it. And there's the stippling kind where you just kind of perforate.
So we electrocute needles.
Not with needles.
What's the last one? It's like a stippling technique.
What I would say is that for the start of this study, do we need to differentiate between the three? Other than, I think it shouldn't include electricity.
Okay.
But all the other ones, are they really so different in reality? I mean, I don't.
Come back when you ask a better question. Is that what I'm supposed to say?
I think it's worth bearing in mind that you can't test all of them, so you've got to choose one.
I was going to say pick one. I think the most common here appears to be the put the needle in and leave it.
So I think it's more like that thing.
The stippling?
Yeah, I've seen that before.
Okay, let's see. We don't have to.
And how much flow requires?
Is it legit to just let them needle on their whatever way they're trained in? Document which one it was. Or are we gonna say only stippling?
I think we should say only one.
I don't know whose that is. Which kind that is.
Let's just call it stippling.
I might be making that word up. I'll check.
Doesn't matter. Control form because you just penetrate it. You could either just make an insertion, or it could be tapping the top of the skin.
The placebo needling?
Yeah. I don't know. But tapping the top of the skin is not inserting it. Yeah. But then they both be treated.
You could also go treatment.
Yes.
Let's go back. What was our question?
I think.
What is your question?
We're making the question. So are we comparing the two interventions? Are we?
I think.
We have to compare to something. That's what I heard.
Stick to a control.
Of just nothing or something comparative?
I mean, that's tough. Should the placebo be like a different treatment that we know isn't effective or something, as opposed to just nothing? Because I feel like if you compare usual care and then add, let's see. Yeah, I
It's a variable.
I don't like it because then if you add the dry needling, that's kind of just sick. It's just a placebo.
Well, the needling is standard.
Yeah.
I'm just saying.
Yeah.
God forbid.
Is there like one of the assumptions is that total treatment effect includes both the potential for placebo plus treatment. So it's an additive model, such that people in the treatment group, some of them will be placebo responders. So regardless of what you do, there'll be a little bit of placebo in there. So that complicates things.
How are you making it harder than we're supposed to?
No, I mean, you're getting at something which is really important. And so the question of whether dry needling is different to placebo dry needling is a completely different question to whether giving someone dry needling versus giving them standard care. They're just different questions. And I'm interested to hear you say that it's proper to have a placebo. It's just a different question. So it's no more or less an RCT if it has a placebo group. And I think this is something which is really commonly thought, that it has to have a placebo group for it to be a proper RCT. But it's just not the case. It's just a different question. And it really depends on, are you interested in whether or the effect of putting those needles in versus someone thinking they're getting the needles put in? Is that what you want to know? Or do you want to know if you give people needles instead of something else? And as I said, they're different questions. And they're both legitimate questions, maybe, but arguably one of them's been answered. But that might be reflecting my own bias. But yeah, it just depends what you want to know.
How about we don't allow them to see whatever is being done to them? The control could be like a single electrical stimulation, which would feel like so that would control the perception that something is being done. And there isn't any treatment effect of just zapping the skin one time.
So that's like your placebo. That you've got that up to placebo. And there's lots of different ways you can placebo control acupuncture. So I mean, people have done it by just not sticking the needles in very deep. So they hypothesize that they've got to go in nice and deep. So if you don't do that, it's kind of sham. You can not put them in the meridian spots, like these maps of the energy flows, and so you can just put them in anywhere, or sort of non-spots in terms of the theory of traditional Chinese medicine versus putting them in the spots, and that will tell you whether this meridian system has some validity. And then some people use like stage dagger needles, so they telescope in themselves. And the thing about some of those is you can double blind them because they go in a light tube, so you can tap it. And if it's a real needle that will go in, it's a fake one, it just telescopes in themselves. So you can do it that way. And that gives you that benefit of getting blind therapies to some extent. But they're all placebo controls in their way that they're trying to get at the mechanism to some extent. Lots of ways to do it.
So this question then comes back to whether, are you interested in a question around the mechanism of dry needling, or are you interested in a question of the effectiveness of dry needling compared to something else?
Effectiveness compared to something else. Is that okay? I like mechanism, but effectiveness to something else is probably.
But the clinician research, like
Well, no, it's not that I don't want to know that. I'm just right. I mean, with that study, I guess I'm thinking
but clinically that you're.
Because that has to do. Again, this is my bias. Is that has to do with like our access to patients in the state got stopped because we had to go defend against dry needling from the acupuncturist. So I would like to just be like, look, this is a thing that's out there, but there's other ways. Maybe.
To be sticking medicine.
But if we show it has no effect though, wouldn't that just like eliminate the question? Yeah. And then we can say, fine, we won't needle, no biggie.
I'm sensing some powerful vested interest.
Some bias.
But I just don't want to be wrong.
Yeah, absolutely.
I'm okay with being wrong. Sandy and Sandy says it out loud. But like we'll just be late adopters if it's shown to be super effective and more effective than
I will, and I will apologize for my slowness. But right now I've not seen anything to make me
But this is the trial we're designing.
That's right.
So you've got your intervention,
Prove me wrong, ladies.
and then within the intervention, you're going to do dry needling, real dry. There's a lot more questions about how you operationalize that. One size fits all. Everyone's going to get the same thing, or is this a technique that should be tailored to what we find in examination, to the presentation in the clinic? And are there issues of dose escalation or not? I'm pretty concerned about all those things. Kind of things you have to kind of operationalize with that eye.
But I can tell you, trying to find out the different techniques and get that pinned down just in searching for it is not easy, because it's probably proprietary information by the organizations that teach it. Kineticor versus the other guys.
There's a broader issue there, isn't there, as well, in terms of if you want your study to change practice, then your dry needling intervention has to be acceptable to the dry needling industry. Otherwise, you just say, well, that's not what we do.
Exactly. Yeah.
So what can you get? Is there a consensus that you can come to on what a good dry needling intervention package would look like to take to trial? I suspect there would be until you got the results of the trial.
This it comes back. There's another consideration here. Is the next step from this, as Neil pointed out. There's question, if you want this to change practice, maybe the way that you set up the intervention has to have some thought. So is this going to be, so assuming it works, how are you going to scale this so it's accessible and all that sort of stuff? But also, is there particular training that's needed, or is it 2-hour session and then you can go, or do you have to do the particular course from whoever? And so these are all issues. They're kind of next step issues. Again, depends what you want to answer, and what question that you're really interested in. The other thing is, if you decide then whether you're going to go with an efficacy question, so this placebo, or an effectiveness question, that might affect your decisions that you make around your population too. Okay, so if you've had your ideas about who your population is based on some idea of whether it was effectiveness or efficacy that you're interested in, and you change that decision, then you might need to go back to your population and go, well, actually, is this really the population that I'm interested in now for this question?
So let's say, let's park P and I.
Yep.
So we want to see, we were erring towards what we're going to compare it to. It was usual care, or no treatment, waiting was control.
Population intervention.
So what do we think of that? Or what are we going to do for comparison? What do we decide? Usual care.
I like the stage diagram.
Oh, so you want to go full on, get the strike burden you in,
I like
do
that
this.
too. I like that too. But then that's
All right, we're going back to the placebo.
Yeah,
That's
that's a
a-
different.
So you're pleasing me.
It's
You
just
not
like
find that much more
seems
interesting.
like.
But I'm less interested in that.
But I also think that it would, and if this, when it's the post-production peer review season, and the people who are wanting the study to be a positive or negative are going to look for what did you actually compare it to? Is that reasonable?
They're going to do that whatever you do.
Yeah, they are.
So you know, should guide you too much.
You can either have two controls, or you could have half the people in each group be on the standard of care during it and not. But then you could sort of have a pure comparison with no standard of care and see if additional standard of care makes any.
Do we actually have a standard of care? That's a thing that's always interesting.
Usual care is a really interesting term.
Yep.
It's almost uninterpretable. And often not even described. So it could be, off to your GP if you need to, see you later. Or it could be, we'll get you in 6 times a week, give you electrotherapy, because the guideline in 1975 said that was a good idea. And it can be anything. And then that's a problem. I guess if you're going to go usual care, so what is that? And again, that speaks to what one is. And also, you have to decide within what is the health infrastructure that these patients are coming through. How does this system work? That's going to inform the decision. So what you'd get for an NHS patient in London, socialised health system, so one has open access to, might be very different to here.
Mm-hmm. I think it's very inconsistent.
Especially with chronic pain.
Yeah, and just state to state.
So maybe standard of care is not a standard of care system that then it would allow us to generalize the results to everyone.
So one of the ways that you sort of get at a similar question is by having it's not a usual care, but it's a sort of a constrained guideline-based care or something like that. So you create an intervention which looks something like what you think usual care should look like. Okay, so, for example, you might design a brief intervention which looks a bit like what the guidelines say and can be feasibly delivered in whatever context that you're. So it's not to say that this is what everyone's getting, but it's saying it's some reasonable standard for what you think people should get in a particular setting. And then you and again, this speaks to this idea that generalizability is a continuum, right? And so then you get something which is arguably reasonably generalizable in a lot of different settings. It's not exactly what people get in practice, again, it answers a fairly pragmatic question, and it's sort of a trade-off.
Should we skip on the outcomes?
I like it, the constrained guideline based. I feel like it would be described like in the study.
And that's really important, regardless of what you decide. Is the report says what actually happened to them. Okay, is regardless of what you decide when you're setting up the study, in order to interpret the results, you need to be able to read the study and see what actually happened to those patients.
Okay,
Outcomes.
how we got my from?
Well, what's the outcome of interest, Mr. Comshaw? What's important?
Yeah.
Make it better.
But what does that mean?
I know. That's a good question.
I mean, we've got loads of information out there of what's important to the system. We tend to ignore it too much. But there's one thing that's really important to the system. One thing. Exactly. And you know, we try and skirt around all these other things, but that's what they want. They want good.
The biggest thing.
We have this tendency to think, well, you know, we'll go for function, we'll go for the right, might better shift those. Actually, the evidence isn't there. The evidence is we shift manually. It's harder to shift those. But you know, if we're really interested in patients' desire for treatment, so what does that mean in terms of the outcome?
And that's perfectly reasonable. But that might not be the question you want to answer. So we started talking about before about this from a regulatory perspective. So what are the regulators interested in? So what's going to state if you want this question to be answered in terms of what care you can provide in a certain environment or whatever else, what's going to make that case? Maybe it isn't patient pain. Maybe it is. Maybe it's care seeking. Maybe it's use of a healthcare system.
Great safety and cost.
Yeah, maybe it's cost effective. Maybe it's, as you say, maybe it's safety. So again,
they didn't die and it only cost $2,000. Yes, you can do it.
Yeah, but I mean, the point is that they're all legitimate questions, but you have to decide up front what it is that you're interested in.
Patients said that by themselves. He said, John,
Patient base. Let's go with patient base.
So what do you measure then?
Yeah.
Pain.
Just curious.
I would think though that
We hang them upside down by their tails and we count how many times they twitch.
Yeah. Watch how they swim.
I would think that there could be different types of response and that perhaps there's reduced pain for a little bit in terms. I don't know, we're just assuming. There might be some people where that's all they need. Or maybe it just lasts a few days, maybe it lasts a few minutes. So
I mean, that's a really interesting question about that. Is what are we looking for? We're looking to see if when you're doing it, it helps someone's pain temporarily. Are you looking to see whether it actually over a prolonged period of time reduces their pain level on a day-to-day basis? That changes the course of their problem, essentially. And actually, it's really hard. So if you look at a lot of drug trials, drugs that aren't supposed to change the course of the disease, but might manage the symptoms while you've got it, people measure an endpoint outcome 6 weeks later. And they often sometimes don't capture. Well, what about just half an hour after I took the drug? We just reviewed a bunch of RCTs of 10s, and none of them looked at pain relief when they're using it, which is probably the one time that people right? It's remarkable. So what are we interested in? What do we want dry needling to do? Or what do we want to know?
Jessica McKinney sent a question. She said, I know I'm missing some words here and there with regard to the discussion of outcomes. Was it mentioned that we tend to focus on outcomes and would be better served to look at one or multiple other outcomes? And if so, where was cost mentioned?
Yeah, I mean, it's a good point. I think you don't just want one outcome, but I think for the interest of getting through this exercise, I reckon you might want to pick a primary outcome. Cost is absolutely important. Absolutely.
Cost of the episode
Re-
here.
Regardless of how many outcomes you come up with, and say, I think it is reasonable to come up with a range of outcomes. From a research perspective, you need to pick one. So one of them is, well, you're going to measure a lot, but one's going to be your primary outcome, and you have to decide what your primary outcome is.
Best way to measure pain. I mean, should we do like a PCS or something? Or just 1 to 10?
Great question. This PCS doesn't really measure
Yeah.
measures how they react.
Yeah.
Right?
Yeah.
It's still asking them. It's still our best measure, right?
So then you just want to do
The
a
person can tell you what they feel. You can tell them.
right, but we have to have a standardized way to.
Isn't the visual analog scale?
We can do it.
Do you think that, what would that look like? What question do you ask? Because that's interestingly varied. How do you ask the question?
So your options, you can say, what's your pain right now? You can say, what's your average pain over the last 24 hours or over the last week or over the last month? You can say, what's your worst pain been over the last 24 hours, week, month? Say, what's your best pain been? Arguably answer slightly different questions.
Something that isn't great practice is to ask all those things and hope one of them is and then just report that one in the paper. And that's not as rare as you think.
But I mean, you can ask all those things and take a mean of those, and people certainly do that. So they might do a worst, best, and average over a time period and take a mean of that. And there's some argument that that's more valid than just one of those things.
You need to think about your anchors as well.
Yep.
No pain to. I mean, the worst I've ever seen is very pain. It was in a long. It was in a journal you can find. From no pain to very pain. Very painful.
Well, then there's worst pain imaginable versus worst back pain imaginable. So there's slightly varied outcomes for that.
I like worst pain imaginable. You'd be trying to have home. Can't get worse than 10.
But I think also that idea of do you want or do you think it's more feasible or more likely that you're going to shift where these people are on average, or do you just want to take the edge off their worst pain? And that might affect whether you ask something about their average pain or about the worst pain.
Also, there's a definition of clinically significant reduction, which is usually 20 or 30% reduction of whatever their baseline is, which is controversial.
So then you start to touch on this idea of effect sizes, and I think Neil's going to talk more about that later. But that's the next step. So this is really about we're defining this question, and then we're going to.
Is there significant reduction in
Like as soon as they're done.
I think
I
like
think
immediate,
multiple.
but immediate and then some time follow up.
Yeah.
So like immediate 1 week and a month.
So there's lots of options there, right? So you can go at different time points and compare the two groups at those different time points, or you can model what happens over that time period and get an idea of the difference between groups over a time period. So that might be over, I don't know, 1 week or 2 weeks or 6 weeks or 3 months or whatever you like.
will vary in how quickly they respond. Or there could be like a brief sort of placebo-like response that can balance this out. So you could you could model the sort of the regression line for each participant from, I don't know, immediate EAS to reduction of EAS to 1 month later. So there'd be multiple time points and you find sort of a straight line that fits each person. You could compare the slopes.
You also have, and that's absolutely reasonable, and it's a good way to go. You have sometimes this sort of a bit of a tension between what you think might be most useful for the patient, right? So ultimately, best case scenario, you want the patient to be better forever, okay? Right? And yeah, so that's what you want, right? And so, and actually what then you're interested in is, you're probably more, from that perspective, more interested in this sort of longer term side, right? But then there's a bit of a tension then, right, between you're going to give a fairly constrained intervention. I don't know how long this is going to last, for a week or 2 weeks or whatever it is. You really think 12 months later that's still having an effect?
How often can they come in for monitoring?
Well, that's a question for your eye.
We have to stop. We have to get away from
So it's almost a sort of dose question, right?
I asked Jessica for some input on this because I know that she's got actual familiarity with the topic.
Right.
I told her none of us here know. She doesn't know. She says, I don't know, actually. I think Kineticore teaches a variety of approaches and encourages the provider to make a decision based on which techniques are most appropriate for the given circumstances finding the patient. Which might be why I can't find a clear answer to what's done. We have a variety of options.
Yep. And so this
Thank you, Jessica.
gets back a little bit to the point I made about the intervention, that you can constrain that really strongly. You say, okay, people are going to get this many needles in this spot this often, or you can say to the clinician, you can have somewhere between 1 and 4 treatments over 2 months. You can use somewhere between 1 and 10 needles, and et cetera, et cetera. Or you can say to the clinician, you do whatever you like. Or you can give them a specific training package and then say, go ahead and do whatever you like. Again, these answer slightly different questions. And so this is about what you want, what's the information that you're really interested in here.
How many training, like how many schools of thought are there for training programs?
There's at least 4 different major organizations: Kineticore, Dr. Ma, Ron Domerholm, and then the guy who electrifies it.
How about training of the experiment or the person applying the treatment through all 4, where they then their results would be acceptable from that perspective, but also it would there's, I don't know, some sort of common common approach to all of them. Then
So one of the things that you might consider doing when you're setting this study up is inviting someone from all of those and saying, guys, let's come up with
a consensus.
Yeah. And it might not be possible, but that might be your best bet in answering a question which is relevant and across. And so, you know, and an example of that, I don't know if you guys have seen recently the radio frequency denervation study came out in JAMA for back pain. And that study was really set up, and it took them bloody ages to set it up. Part of the reason being was the people who do it were part of the team which designed that study. And the reason for that is that issue that you talked about before. You don't want them to come around at the end of this and say, yeah, but that's not the way I do it.
I like what Neil had said about
Although people outside of Holland might.
Absolutely. I mean, you can't solve the problem completely, but
the consensus would hold exactly until the results came out.
yeah. Look, I mean, it doesn't solve the problem completely, but
yeah, I think that's a good idea.
It would probably go some way towards, and so then this is even once you start map this out, you've got to make decisions about who's going to be involved in this. And one of the reasons for including people is to have people who are influential to have some skin in the game.
Well, but also then your intervention that's being provided more closely matches what's provided.
Yeah, sure, for sure.
I've learned that to my cost. That's all about basic brain stimulation. My lack of formal relationships with that industry almost enables them just to not attend to that, which is a shame.
Yep.
Should we wrap up what your study looks like then? Because we're running over. It's nearly coffee time. So, what do we got? What do we got? We want to know if dry needling helps people with chronic non-specific low back pain.
We started out really strong.
Do we not? And we realise that's really difficult. Actually, can we come back to this? So we're going to take them off all their meds?
No meds that impact pain processes.
Right. Okay. I mean, what do you think that does for us?
It really ramped up people.
No, I think it was just people not taking them off their meds, just people who aren't on them.
So, right. Okay. So you're going to find a bunch of people with chronic non-specific back pain affects their life that aren't taking any meds.
Or
that might be
take
like a
them off
unicorn.
the drugs that don't work, which they're already taking. Some of them might help a little bit, but just in terms of, we wouldn't be able to say the effect is specific to dry needling if they're on these other medications, because it could be.
Would you not though? If you randomised a bunch of people who are on various meds and you had a big enough sample, you randomised successfully, and there was a difference between groups after the dry needling, would you not draw a causal inference?
Not causal.
Would you not?
Well, for instance, like opioids, that if there is an endogenous opioid response whenever you cause acute pain to a certain degree, that would, I'm not sure if opioid drugs augment endogenous responses, but that's possible.
Yeah.
So that's an augmented effect of the needling due to the medication that they're taking.
So there's an issue of whether the drugs might interact in some way and affect the impact of it, whether the treatment works or not. So by removing meds, you kind of remove a source of noise, possible confounder. But if you were to randomly allocate people on meds, then you essentially balance that issue across two groups.
There's only one way I know that you can't. You mean have the same amount of people with SSRIs,
Yep.
et cetera?
So,
But they have, so there's something called a medication quantification scale that sort of, based on the dose and the type of drug, creates a weighted number that you can then use as a covariate. That would be the only thing I would think of that would allow for the effect of these very different, drugs to be compared. And I mean, they do completely different.
yeah, I mean, I would trust in randomisation.
But you're not looking to isolate the effect of these drugs. And remember, we're talking about a population mean difference.
That's true, but what if the variability introduced by those drugs is greater than the treatment effect that you're looking at? Then you won't find a significant.
So to some extent, this speaks to the population that we're interested in.
So is it, do the people we see clinically end up on a variety of different medications? Yes.
Okay, then at least have them on the medication for like 2 months or 3 months to where there won't be any variability due to
Can't have certain.
Hold them stable.
minimal.
All right, so we got our stable meds.
meds.
I don't think we need to. We've got dry needling, which is going to be stippling.
Well, or we're gonna do what's what's done and get a consensus from the people who teach.
So we're going to go through an informed process of engaging with the community and coming up with an agreement on what a tailored, dose-appropriate intervention looks like that has fidelity.
Yes.
Awesome. See, I think that's really
No, it's brilliant. I think it's
awesome.
yeah. For sure.
And you know how often that doesn't get done, but actually it's really important. we're going to compare it to placebo dry needling with a stage dagger. Is that right? Needle, not actual stage dagger.
I call it stage dance. So
Yeah,
it's-
there you go.
it sounds fantastic.
So we're asking a question about efficacy there, i.e. does dry needling work better than pretending to do it in an incredible way?
On top of just guideline-based care.
On top of guideline-based care, whatever that might be.
However, it's defined in the study.
And our primary outcome is pain intensity, average over the last day, or maybe some inventory of pain intensity measured on visual analog scales. Secondary outcomes, what would you throw in there?
Well,
I'm going to allow you 3.
cost needs to be one for our current climate.
So cost effectiveness, you want
Yeah.
to do a cost effectiveness sort of analysis within this. Okay, anything else?
Cost. This is an aside, and I'm not sure this is. I want to go down this particular wormhole, but cost effectiveness analysis is really tricky with placebo. But anyway, that's by the by.
Because it's not factual.
That's right. Yeah.
Right?
But anyway, I'll leave that for now.
Anything else in
That
there?
was one of the things Jessica was really, she's like, cost is really important. So it's,
Yeah.
Anything else? Anything else?
Yeah.
Anything else?
Some sort of movement related. I don't know, if they produce pain, what will they be able to do with it?
So some scale of function or disability, which is a core outcome. Right back. Anything else? Something you'd want to measure for your cost effectiveness, if indeed that was possible to do, because most cost effectiveness analyses are based not on pain or on disability, but on quality of life.
Qualities.
So the unit of most cost effectiveness analysis would be a quality adjusted life.
Okay.
Which is a tricky concept to get your head around as well. But we're not doing
We're not
cost
going down
effectiveness today,
it.
which is kind of awesome. So there we go. So what do you think? We've gone through that process. It's taken us a while. For what should be a pretty simple question on paper, right? Does dry needling work? And I think, we could spend the whole day nailing this down and we still wouldn't have it. I think when you're picking up a paper, trying to get a clear sense of what the question is and how they've operationalized it, and whether you think the decisions they've come to are actually good decisions, defensible decisions, and understanding the implications I think they have for interpretation. What does Dave actually mean? Because depending on what we've done here, what we're going to done with that answer, very, very different. You think, Steve?
Yeah, I guess that I sort of run this sort of group work at various places, and I really enjoy watching people sort of coming to these sort of decisions and all that sort of stuff. Because I think it's really important to understand that process. As Neil said, it looks simple, and if you get just PICO, all right, bang, 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 it's really straightforward. But understanding the implications for the decisions that you make on all these points is really important, because if you don't understand that, as I said, I do bang on about questions a lot, but you have no way of interpreting the results of the paper.
And you shouldn't assume that researchers always go through this process in the way they should.
And they don't always do a good job.
I was gonna ask if this had to come up with like an ideal question. How much does the constraints of what the researcher has like access to, or how they're gonna?
It's massive implications.
So does that usually factor in more?
Yeah, there's the question of what's
A better
actually
question
deliverable,
would
what's
be-
fundable.
Yeah. So
What resources
maybe
you've
they
got.
have a good ideal question, but not
Absolutely.
able to implement it. Yeah.
There's always a tension between what you really want. It's
Yeah.
like Christmas. As I tell my kids, one of the best examples of this, I did a workshop at Cochrane when I was learning to be a Cochrane, but we're all people from all over the world, all different disciplines, and they said, "What's your question?" did this, broke into PICO, and there was a guy there who was interested in traditional Chinese herbal medicine to prevent early miscarriage in people at high risk of miscarriage. We got to outcomes, and he had this list of blood tests and other physiological measures, and he stopped, and the room was quiet, and then the guy who was facilitating it looked around, and he looked a bit puzzled. He said to him, "Do you think you want to put actual incidence of miscarriage as an outcome?" He said, "Oh no, we'll never show a difference on that." That's crazy. But it was just such a golden moment because it really happened. Anyway, we should have a quick coffee.
Yep.
We're definitely running over. So should we say 10 minutes and then kick off for 5 minutes?
Mm-hmm.
You happy with that? Is Jess all right at the other end?
She is.
Is Jess in the air?
Just in the
Jess in
air.
the air, Jessica
Jamie's at
is
work.
Very happy for the interdisciplinary discussion.